Good evening, everyone. Tonight we're going to be doing your questions and answers all about lipids and cholesterol. So thank you to all who submitted questions, and we'll get to it. All right. First question is, high LDL really a bad thing if your diet is clean and healthy? So, I'm not going to tell people, nutrition is not important, but your light environment trumps your nutrition environment. The sun grows your plants that you eat, or the animals that eat the plants. You're basically digesting sunshine. So get your light environments right. If you don't get your light right, it's really hard to get your health right. But that being said, LDL-C is really what this person is mentioning. It's really more about the LDL-P that really predicts risk. So LDL-C on your traditional cholesterol profile really does not tell you if you're going to have a heart attack or not. That being said too, the LDL-C, it's transporting cholesterol from the liver out to the muscle cells, the other organs that need cholesterol. It's mostly the particles, not the LDL-C per se. The LDL-C is, the passenger inside the particle. But, it really depends on if that LDL-C is getting deposited into the walls of the arteries and depositing and building up plaque. So that would be the concern. So this is where a CT coronary calcium score or a carotid intimal medial thickness test will tell you, what's going on with your arterial health. If you have plaque in your arteries, then it's a problem. If your calcium score is 0 and you have normal vascular aging on a CIMT, then your nutrition plan probably is working well for you. Next question is perimenopause and worsening of lipids, what to do. So, heart disease is still the #1 thing that takes out people. Women tend to be protected for about 10 years more than men because of the protective effects of estrogen. Estrogen tends to help keep HDL on the higher side and LDL-C on the lower side. But it's much more about the particles. But that being said, when the estrogen levels start to drop, the LDL-C and the particle count tends to rise. And the risk of atherosclerosis starts equating the same as a man at that stage. So it is not a recommendation to start hormone replacement therapy just to affect lipids, but if you're on hormone replacement therapy, to treat perimenopausal symptoms, your lipid profile is going to return back to the way it used to be. There are some benefits of estrogen therapy at lowering lipoprotein(a), which 20% of the population has. Again, not a reason to start estrogen replacement therapy, but that is the main benefit of hormone replacement therapy on lipids, is keeping the LDL-C on the lower side and the HDL-C on the higher side. Why do they get such a bad rap? I assume this means just cholesterol in general. Cholesterol is a waxy substance. It does not float in the blood by itself. So there's something called the lipoprotein, which is made in the liver. It's like a cargo ship. It transports or ferries that cholesterol, triglycerides, vitamins, and then these phospholipids, which are kind of building blocks to the cell, around the system. So I think it's a little bit simplistic to say, cholesterol is good or bad. Cholesterol is just cholesterol. Without cholesterol, you're dead, essentially. You need it to make your sex hormones. You need it to make your bile acids. You need it to make your cell membranes. The only thing you don't want is cholesterol to be deposited into the walls of the artery, contributing to a plaque buildup, like a pimple on the wall of the artery that, if it ruptures, causes a heart attack or stroke. So again, simplistic to say good cholesterol, bad cholesterol. But sometimes when there's only a 5-minute office visit with a doctor, not my practice, I spend an hour with my new patients and at least 30 minutes with my follow-up patients. You really can go over these 8-page deep dive lipoprotein analysis reports, that either Cleveland Heart Lab or Boston Heart puts out. But if you're only looking at total cholesterol and LDL cholesterol and HDL cholesterol and triglyceride, sometimes it's very binary. This is high, we want it lower. You want it low, figure out why it's low if it's not being driven down by drugs or supplements. So you need to dive deeper. How healthy are the arteries? The CIMT and the carotid scan is a good one, and that CT coronary calcium score or calcium scan is a test to see if you have hard calcified plaques in your arteries, and you need an advanced lipid profile to really tell you, do you have bad cholesterols. So next question is about the testing. So the best comprehensive test. There are multiple companies that do these advanced lipoprotein analysis. I generally recommend people either get an NMR analysis, nuclear medicine resonance analysis, or an ApoB particle is similar to that. Those are the better predictors of risk. It's the particles that transport the cholesterol around that's more important to know than the cholesterol itself. Typically, Quest labs will do something called the cardio-ion mobility. It's similar, but I tend not to use that one. I use the NMR a little bit more. And they acquired Cleveland Heart Lab a few years ago, so they're kind of a subsidiary of Quest. So if you get access to a Quest facility, you can get these advanced testing. Boston Heart Diagnostics also does the advanced lipid analysis, but some of the benefits that the Boston Heart does is they do a test called the cholesterol balance, which determines essentially, are you overproducing cholesterol particles, so too many cargo ships leaving the liver, or do you have an issue with the gut recycling the lipoproteins too effectively, which up to 1 in 5 people have that problem. So the cholesterol balance test with Boston Heart, they also have a test called the oxidized phospholipid on ApoB, which is probably the most sensitive cholesterol metric to tell you, do you have bad cholesterol that's more likely to damage your arteries. And then everybody should get something known as lipoprotein(a) or Lp(a) checked at least once in their life. It's the number one genetically inherited lipoprotein that can increase cardiovascular risk. In a couple of days, it's actually World Lp(a) Day, and I'll probably do something in my story explaining my current thoughts on Lp(a) at that time. All right. So next question, when to worry. It's all individualized to your individual context, and it's one of those cases of test, don't guess, what's going on with your arteries. So just looking at a static number, isn't going to cause, panic or worry. But if you've recently had a heart attack, a stroke, you have a stent, you've had bypass surgery, you're high risk. There's certain numbers that are going to be red flags for those individuals. If you're a 25-year-old woman, with high, quote, cholesterol, that's a different story. If your arteries are generally healthy, and you've shown it's healthy by an endopat, a max pulse, a CIMT, a calcium score, there's no evidence that you have any endothelial dysfunction or plaques building up in your arteries, then, cholesterol floating around in your bloodstream isn't a concern, because again, the main job is that the cargo ships that the liver is making is transporting those to your muscles. Your muscles are requesting energy. Cholesterol is just, being transported in that lipoprotein. The only problem is if that lipoprotein makes a detour, gets stuck to the wall of the artery like Velcro, gets retained there, and then it may dump its payload into the wall of the artery. That's the problem. But if you have only a traditional lipid profile, then if your total cholesterol is over 300 or your LDL-C is over 190, it's a possibility that you have something known as FH, or familial hyperlipidemia syndrome. So you may have an issue with your LDL receptor not clearing these lipoproteins effectively from the blood. Some patients who are on a keto diet will see that kind of phenotype. So you want to know what your baseline levels were before you started a keto diet, and if it jumped up significantly, that's probably due to hyperabsorption of fats in your gut level. Some people have an ApoE gene that will help kind of facilitate that recycling of cholesterol a little bit more effectively. So if they have an ApoE4 gene, you'll see that sometimes. Don't worry just looking at a static number, but if you do some testing that looks at the arteries and there's endothelial dysfunction, there's inflammation in the walls of the artery, or there's actually hard or soft plaques in the artery, then you need to figure out, okay, what else is going on in the system? Because often it's a combination of something: endothelial dysfunction, inflammation, and an ApoB containing particle getting stuck to the artery. So fix what's causing the endothelial dysfunction or the inflammation, and those ApoB particles maybe aren't going to be able to stick to the artery then. The next question is, does dairy have a negative impact on cholesterol or heart health in general? It really depends on your context. Do you have any GI side effects from dairy? Some people are lactate deficient and they have more bloating, diarrhea, gas with dairy. But if you don't really have any GI side effects, a little bit of dairy isn't a major concern from my standpoint. Again, it's one of those test, don't guess things. There's all types of different SNPs that will determine, how your body's going to process dairy and other foods. So you always want to have kind of a baseline level of whatever going to be checking, and then if you're going to make a dietary change, either adding something to your diet or restricting it, then repeat labs a few weeks later and see what the change is. So it's again one of those test don't guess scenarios. Be an N of one, a biohacker, and see what might make or break your own biochemistry. The next question is about ezetimibe. So would I use ezetimibe with someone who cannot tolerate statins to lower the LDL-C? So ezetimibe is the generic term or medication for something that used to be known as Zetia. It's a medication that works at the gut level at blocking cholesterol reabsorption. So again, it's generally one of three things. It's either that your liver is pumping out too many of these lipoproteins, so it's like too many cars on the highway, too many cargo ships are getting pumped out into the blood vessels, or it's an issue with the LDL receptor on the liver. So it's like a catcher's mitt that's supposed to clear the blood of these LDL receptors. Clear the blood of these LDL particles. If you don't have the receptor out or the catcher's mitt, then the little cargo ships keep circulating around in your blood vessels. Once the LDL particle has been retained in the liver, the body puts it into the bile, puts it in the gut, and you're supposed to get rid of it through your GI system. But in about 1 in 5 people, there's a receptor called the Niemann-1 PIC-like receptor, like a bouncer, just opens the doors back up, says this is perfectly good cholesterol particle, and why are we getting rid of it? And sends it back through the portal circulation, and basically sends it back to the liver, and it goes around the circuit again. And your body then has to clear it again. So, ezetimibe basically keeps that bouncer's door closed, and so if your body said, time to get rid of this stuff, you get rid of it. So ezetimibe is a good second-line medication if somebody is intolerant to statins. So I've been definitely using ezetimibe since probably at least 2002, so almost 20 years. And so it does help lower the LDL particle counts, but it's one of those ones where there are other things that you may want to do first. There are other medications, there are other supplements that can work on the production side of things if that's an issue. Again, that Boston Heart test, the cholesterol balance test, will tell you if that's the issue. If somebody is not a hyperabsorber of sterols, the big one being testosterone, if you're not a hyperabsorber of that, then ezetimibe might not necessarily work that well for you. Sometimes it's worthwhile trying, but the people who are hyperabsorbers are going to tend to benefit more from ezetimibe. And then the next question is how to raise HDL-C naturally. HDL, mistakenly gets called good cholesterol. Again, no such thing as good cholesterol. There's just cholesterol. There's different lipoproteins that vary the cholesterol to different parts of the body. HDL has a couple hundred different jobs. One of them is reverse cholesterol transport, basically taking cholesterol from the system back to the liver to recycle it. But HDL is also very important for the immune system. It's a good marker too of your liver's health. If you have really, really low HDL, then maybe something going on with your liver. Your liver's inflamed. You're insulin resistant. If you've always had low HDL since you were a little kid, okay, maybe there's a genetic issue with your body, able to make the ApoA proteins that sit on the outside of HDL. But HDL is somewhat of a metric of your current lifestyle. So if you're getting enough exercise, or eating a generally recognized quote healthy diet, your HDL should be at a certain level. So exercise is probably the best lifestyle thing that will boost HDL. A combination of aerobic and strength training. And then from a nutrition standpoint, most likely the biggest bang for the buck would be DHA containing foods, so mostly seafood. So that would be the best way to quote raise it naturally. Side note on it, there was multiple drug trials done 10, 15 years ago that were using different pharmacological agents to try to raise HDL, and they always did raise HDL, but in the trials, the people who got the medication that raised their HDL always did worse. They had more events, or they actually even died more often. So raising HDL through any means other than lifestyle has not proven to be a win for people. It just shows you that Mother Nature is pretty smart in the way she put the design together. And so, you don't want to be breaking things that Mother Nature wanted it to be a certain way. The next question, what is the marker I should be really worried about when my cholesterol plus triglycerides are high? So if your triglycerides are elevated, your stored up energy, there are concerns that potentially you're insulin resistant. You're headed towards prediabetes. Most lab panels, at least in the US, they'll say your triglycerides are normal if it's less than 150. But ideally, you generally want to see your triglycerides less than 80 to say you really have good control of your glucose disposal. So a hemoglobin A1C, your 90-day average blood sugar should be checked in people with high triglycerides, a fasting glucose, and really a fasting insulin, because often it's your insulin levels are going to be higher, well before your blood sugars start rising or your hemoglobin A1C starts increasing. But it's sometimes a good tell of what's going on with the person's insulin sensitivity when you start seeing issues with their lipoprotein analysis. So they'll start having increases their small LDL. They'll start having higher levels of LDL particle counts. They'll have high levels of VLDL. So you can kind of read into their lipoprotein panel, years before you're going to tell the person, hey, you're pre-diabetic now. The next question was about a high LDL, but the bigger particles. On a NMR analysis or a cardio IQ from Quest, they will break down the LDL particles by size. And there are large particles and there's small particles. It used to be thought more that the small particles are the bad ones. I used to use an analogy about your artery walls being a tennis net, and the large particles being a tennis ball. They're not going to get through that net, but the small particles are like a BB or like a golf ball. They're more easy to get through the net. It's true in ways, but it's more that the small particles have a longer residence time. They basically stick around in your blood vessels for 5 days floating around, where the larger ones are there for 1 or 2 days. So there's just less chance that the large ones are exposed to things that are going to cause them to oxidize or rust. The small ones tend to be more genetically driven, but also they're more small particles when people are insulin resistant. So again, it's one of those tells sometimes that if you see a lot of small LDL particles on NMR analysis, that person may be not handling their glucose load effectively, or they're getting too much artificial light at night. They don't sleep well. They're not doing resistance training that stimulate their muscles to put out a GLUT4 receptor to suck the blood sugar out of their blood vessels. So there's many things that can raise your blood sugar, but if you have a lot of small LDLs, that can be a cause of it. All right. So question, if you can get plaque buildup regardless of high or low cholesterol, then why statins? So I would kind of frame it as a little bit more about ApoB containing particles. So ApoB is a protein that sits on the outside of the lipoproteins. So if the lipoprotein is a tennis ball, it's spherical, again, fills up full of cholesterol, which is building blocks for your hormones, your bile acids, your cell membranes. The lipoprotein also fills up full of triglycerides, which are energy for your cells. There's vitamins inside the lipoproteins. So it's not so much that there's high or low cholesterol, it's depending on how many lipoproteins are. So if you have a low ApoB count, so an ApoB count of 60, you're very unlikely to be adding plaque to your arteries at that point. It's like cargo ships going through the blood vessels. There's less shots on goal when there's only 60 ApoB particles in your blood. If you have ApoB particles of 200, more shots on goal, more likely some of them are to get stuck in the walls of the artery. So the statins are, somewhat of a loaded question. Statins are tools, and I think there might be some more questions about statins, which we'll hit upon. But match the tool to the job. So if somebody again has had a heart attack, they have a stent, they've had open heart surgery, they've had carotid endarterectomy, they've had a stroke. Those people are very high risk to having a second event. Statins are tools that help significantly lower the second time of having an event. Where the murkiness or the grayness comes in is in a younger person who's never had an event and just has high cholesterol metrics on a blood panel. Now statins may be overkill in that individual. Again, it typically takes endothelial dysfunction, inflammation, and a high ApoB containing particle count to develop plaque. So if you only have one of the three, you're probably not that concerned about it, and statins might be overkill in that situation. So again, that's why I can't blanketly tell people, well, everybody should be on a statin or nobody should be on it. It's that individual sitting in front of you. What is the endothelial health on an endopat or max pulse test? What does their carotid artery look like on a CIMT? What does their calcium score test look like? If their calcium score is 0, statins are not going to probably be the best tool for that individual, except in some very rare cases. If their calcium score is over 400, the statins are probably going to help reduce an event, a heart attack, a stroke. So you're right, the lower particle counts will likely have less plaque in their arteries over time, but again, it's one of those cases, test, don't guess. Do lipoprotein analysis and take a look at the arterial health through whatever non-invasive metrics that you have available to you. All right, another statin question. So, don't statins do more harm than good? So, loaded question, obviously, but no, not in the overall sense of things. Now, do statins have side effects? Of course they do. Anything you put in your system can have a side effect. The statin's main side effect is musculoskeletal, so muscle pains, muscle weakness, muscle fatigue. That's the general thing that can cause side effects that are bad enough that people have to stop taking statin therapies. But there are different statins that tend not to cause that as much. So the lipophilic ones, the rosuvastatin, the pravastatin, tend not to cause that as much because they are more liver specific. There are neuroagents that are not statins. One medication is called Nexletol, or Nexlizet is the combination that has ezetimibe or zetia built into it. It is, again, specific to the liver. It does not get into the muscle cells. So, again, use the right tool for the job. Again, anything that goes into your system, there's risk versus benefit. If you just had your chest cracked open and had a 4-vessel bypass, you might be willing to take more risk taking medication. You're a 22-year-old female with, quote, high cholesterol and you're on a keto diet. Maybe we need to talk about nutrition, changing of your saturated fat intake, or potentially using ezetimibe if you're an ApoE4 carrier. So use the right tool for the job. Again, this is not a straightforward question. How to convert cholesterol into testosterone. Cholesterol is a building block for testosterone. So, things off the top of my head, you got to really focus on your sleep quality. If you're not sleeping right, you're not going to make optimal sex hormones because your body's like, I'm too banged up from whatever other stresses I've been in, during the day. It's not time to reproduce, so we're not going to, focus so much on making testosterone. The other thing is, are you getting the proper light signals? That morning sunlight in your eyes from sunrise, for the first hour is key at optimizing your testosterone. Red light is, reparative. It's, very important for multiple processes in your body. And not many guys are using red light to the regions that, boost testosterone. So if your gonads do not see the sun, you're probably not going to have optimal testosterone levels in many cases. But cholesterol will, ultimately get converted into testosterone. So, it's mostly through your gonads. So this is a little bit of a side rant on it, is that, I sometimes get some consults for patients saying like, oh, my testosterone's low because I'm on cholesterol lowering agent. It really is a little bit more complex than that, because what are floating around in your bloodstream is not necessarily what is going on in your gonads, your adrenals, or your brain. Your brain has its own pool of cholesterol. So, your liver's not making lipoproteins that deliver to your brain to deliver cholesterol. The cholesterol is so vital to the brain makes its own supplies. Every cell actually makes its own supply of cholesterol. Every once in a while, the adrenals need more cholesterol than they can convert over to hormones quickly. So sometimes your liver does have to deliver cholesterol to the adrenals so they can make more, stress hormones and such. And sometimes the gonads do as well. But if that was, the case, then there's some other agents sometimes you can use for that person and just change up the supplement or medication regimen if that's really a concern. But it's not a blanket statement that all lipid-lowering agents are going to lower your testosterone. All right, so I think I might have got through all the pre-written questions. I'm going to scale back here and just see if there's anything that I can answer that does come in from the guys that are watching currently. Thank you. All right. Somebody's asking about if the calcium test shows a blockage, is there any other way than, and I assume it's mean taking a statin, but I'll look a little bit further, see if there's any other follow-up part to the question. But the calcium score test doesn't necessarily show that there's a blockage. The calcium score test, or the CT coronary calcium score test, is a low-dose radiation scan that's looking for calcium in the walls of the artery. Calcium is supposed to be in your bones and teeth. Calcium in the walls of the artery indicates that basically you've had a break into the walls of the artery. The endothelium had been damaged at some point in the past. The intima, the first layer under the endothelium, swole up because of inflammation. Soft plaque started developing in the walls of the artery, and then the body ultimately fibrosed it and started to calcify it, to take care of it, basically trying to sandwich in the damage. So calcium is a late-stage finding of cell death. So if you see calcium in the walls of the artery, you also know that there's soft plaque in the artery, and that's what you're actually concerned about. The hard plaques sometimes are going to cause symptoms in people if it's a significant enough volume of hard plaque. That person may develop angina or chest pain or shortness of breath or exercise intolerance. But what you're really concerned about is the soft plaque that sits on top of the calcifications. It's the soft plaque that can rupture like a pimple and can lead to a heart attack or stroke. The calcium score test is a great tiebreaker in some instances. If your score is 0, many times lifestyle and potentially supplements are the better option for you. Your calcium score is over 400. Medications may be the better option in that case to more quickly put out the fire while you're trying to figure out why the fire got started. So calcium score test, for the most part, if you're over 40, you should consider the test. The only people who really should not is the people who've already had events. You had a heart attack, you got a stent, you've had bypass surgery, you've had a stroke, you're high risk. The calcium score test isn't going to add more information to you in that case. Yes, what is a desirable calcium score? 0. But that being said, if you're 45 or younger, if your score is not 0, that's very high risk in anybody's book, and likely that person has lipoprotein(a) or some other genetic predisposition to it. They're probably also potentially insulin resistant. So if your score is greater than 0 at a young age, you need to do a deep dive with somebody like myself. You can figure out why that plaque is building up there. Now you're 80 years old and your calcium score is 50. Okay, it's pretty expected you're going to have some degree of plaque in your arteries, but it's pretty low. But a good score when you're 80, if it was 0, what other person's doing is working for them, so don't break them. So test, don't guess, and everybody is a N of 1 experiment essentially. So your environment will determine what happens to you. So test, don't guess. All right. Somebody's asking about is high pH in the body a risk to heart health? I don't really have to answer this question in a way that probably would answer your question, but if you blood, you're again back to Mother Nature, and your Mother Nature, the acid-base metabolism wants to keep you at a very tight range. If you're either too acidic or too basic, bad things tend to happen. You tend to have more heart arrhythmias, and often bad things such as death will happen if you're too alkalotic. So it's not that it's necessarily intrinsically bad to the heart, but what is causing the body to be so acidic or alkalotic? That's the concern you need to go after. Somebody's had a good question. Does the CIMT, the carotid intermedial thickness test, check for soft plaque and hard plaque? Yes, it does. But the main benefit of the CIMT is its ability to look at the intima. How thick is the intima is a good metric of how much inflammation is in the wall of the artery. If your intima is normal thickness, you don't have much inflammation then. This is where the vascular age will be calculated from. So if you're a 50-year-old individual and your CIMT vascular age comes back at 50 or less, then whatever you're doing is working for you. But many times I've seen people come back and their CIMT shows their vascular age is 70 or 80 years old and they're only 50 years old. So as Thomas Sendham from the 1600s said, you're as old as your arteries, or man is as old as his arteries. So the vascular age is a good, kind of wake-up sign for some people to say, hey, what I'm doing in my lifestyle or my current supplement or medication regimen, what's it doing to my vascular system? But if you have soft plaque, yes, it will measure the soft plaque. So, it's not uncommon to see some mild, less than 30% plaques in the arteries. And if you have a more mixed or calcified plaque, it will see it as well. But it's not generally, the CMT test is not the right test. Somebody, auscultates your carotid artery and hears a loud brewery or turbulent flow across your carotid. It's very possible you have a 70% blockage in your artery and you need a carotid duplex to take a look at that one. And somebody's asking, is it open question night? It's mostly about cholesterol and lipids, but if it's pretty cardiovascular specific, I may answer it tonight. There was somebody who put in a question through Facebook that won't show up when I pull up my Instagram live questions, asking if I could go over or basically explain the cardiac Q test a little bit more. That's the standard advanced lipid profile panel from Quest Labs. Again, I don't personally check it in my patients. I tend to use the NMR from Cleveland Heart Lab, or just looking at an ApoB particle, which almost any lab company can do. But it's been a couple years. I had done a video, it'd be on my YouTube channel, so it's Michael Twyman MD on YouTube, where I had gone over how to read your own advanced lipoprotein panel. But that's a great idea. So now next Monday night, 6 p.m. Central Time, I will go over one of my recent lab panels. I did a kind of split test of Cleveland Heart Lab and Boston Heart Diagnostic Labs on myself. So I'll pull up my labs on the screen and just go through them line by line and kind of say, okay, this is what I'm looking at when I'm going over one of these lipoprotein panels, and what you can ask your doctor if you had that kind of testing then. All right, so we're at the bottom of the hour. If any questions come in, I will answer them. But again, next Monday, 6 p.m. Central Time, we'll go over how to read a lipoprotein advanced test. If you're interested in the kind of testing I talked about tonight, the endothelial function test like the EndoPAT, the Max Pulse, the carotid intimal medial thickness test, the calcium score test, I do offer those type of tests at my practice here in St. Louis, Missouri at Apollo Cardiology. The best way to reach us is generally through our website. It's drtwyman.com. Just the way it's spelled up here on my Instagram handle. And if you're so inclined, I do offer a complimentary 15-minute get to know me and the practice type of Zoom calls. And I don't answer any specific medical questions, but if you have a question about like how does our practice really work for you, we can kind of chat and see if we're a good connection. And if you're interested in these type of testing, we'll try to get you set up to do them then. All right. So that the question you're asking, I don't have an answer for that particular one at this time. So I'll let you guys go for tonight. I appreciate your time and attention, and we'll see you again next Monday, 6 p.m. Central Time.